hold on one second. I had to put on the recording. I almost forgot. We're so happy to have Multi-Specialty Healthcare with us today. They have been tremendous supporters of our organization for many, many years. Christy Peters, of course, is our representative, but I know many of you have worked with many of the fine doctors. And with that, I am going to turn things over to Larry Feldman, who's going to introduce the program.
Thank you and good afternoon, everybody. Hope everybody's enjoying a good lunch hour. We have an action-packed program for you today. I'm Larry Feldman. I may have met some of you because I've been a trial attorney in the greater Baltimore area for a little bit over 2 decades. And for the last few years, I've served as general counsel to Multi-Specialty Healthcare. So I've really gotten a good idea of the medical side of things that I don't think I fully understood in my days just as a personal injury trial attorney. And that's where this program arose from. It arose from my trying to answer questions for other attorneys and from hearing questions in the courtroom for many, many years, such as, well, why do we have to pay? Why would they charge for exercise? You can do exercise by yourself. Why would they charge for a heating pack? You can buy that at CVS. And I'm sure these are questions that you've had from judges, mediators, arbitrators in the past. And I'm sure these are things you've had to explain to juries in the past. So our goal today is to give you just a taste of certain areas of our physical therapy practice, what they are, how we do them, and most importantly, how you explain them to triers of fact. I will monitor questions throughout, so put them in the question and answer section. And as time permits, we will get to some questions that you may have. With that, I'm going to turn it over to one of the 4 owners of Multi-Specialty, Dr. Charles Thorne.
Thank you, Larry, and welcome everybody to the Multi-Specialty Healthcare webinar, Explaining PT to Judges and Juries. Just a little bit of house cleaning here. Multi-Specialty Healthcare, with our 33 centers throughout Maryland and Delaware, have been open. We've been open through the entire pandemic and practicing responsible safety measures per the CDC, such as parking lot waiting rooms, robust questionnaires pre-visit, taking temperatures of all the patients that are coming in the door, and we've scoured the globe and our country for appropriate PPE, and all of our providers and staff are practicing social distancing. One thing that has come about that's actually a very positive thing from this pandemic is we've all been able to develop our technology skills a little bit better, which gives us the opportunity to come before you today in a very relaxed yet action-packed and informative setting. So we appreciate that. Have a couple of thank yous before we get started. Certainly to the DC trial lawyers, the executive director, Mary Zambri, who we've are proud to be a platinum sponsor with and have worked with the organization, both with internal programs and community outreach programs. Also, I'd like to thank our general counsel, Larry Feldman, and specifically a senior marketing rep, our Christy Peters, who's been with us many years, and between her and Mary have put this program together. So thank you to all. It is really a privilege and a pleasure to present to you 3 expert panelists today that will go through various pieces of content. First on the list is Dr. Jim Beecham. We call him Dr. B. He is a chiropractor. All 3 folks today are chiropractors, by the way, and whether you know it or not, in Maryland, chiropractors are duly licensed as chiropractors and physical therapists. So all of our chiropractors practice a tremendous amount of additional therapies and hands-on procedures and exercises at a very high level, in addition to providing the primary source of care in chiropractic, the chiropractic adjustment or manipulation, which, by the way, could take up an hour in and of itself. So today we're focusing on the ancillary procedures, the passive modalities of therapy, and how best to to explain those to a trier of fact, a judge, a jury, or a mediator, perhaps. And we're going to also focus on exercise. You're going to see a number of things. But Dr. Beecham's going to start out by taking a deep dive into the passive modalities. He is a graduate of Life Chiropractic West University in San Lorenzo, California. He's certified in spinal trauma. He's certified in manipulation under anesthesia, and he's been with multi-specialty in our Waldorf Care Center since 2012. He'll be followed by Dr. Sam Santoriello. We called him Dr. Sam. He received his doctorate at Life University in Marietta, Georgia, back in the mid-90s. He's on the postgraduate faculty of Life College, and he's done a lot of training of CAs throughout the state of Maryland, along with Dr. Keith Scott. So he has presented a lot of information, and I think you'll find his presentation particularly high energy. Without stealing any of his thunder, he's been with us for 25 years. He's at our Overly Care Center, and he has informed me that he himself has seen approximately 250,000 patient encounters. So you're going to get a lot from his experience as well. Following Dr. Sam will be Dr. Jessica Taylor. She received her doctorate from Palmer College of Chiropractic in Port Orange, Florida. She's a certified athletic trainer and a certified strength and conditioning specialist. Jessica's also been with us since 2012, and she provides care at our Maryland Avenue Care Center in Baltimore. So we have several goals today before we jump into the program. As I said, Dr. B, our first speaker, will give you a deep dive into the passive modalities and why these types of things should be monitored by professionals in office and or through telehealth versus just having your patient or your client go home with a hot pack or an ice pack or a TENS unit that they strap to their belt and leave them on their own. So he'll get into that. He'll get into some of the studies that have been done. He'll get into some very interesting, as interesting as you can make passive modalities. This is the guy to do it. Also, he will come back to us later on in the program with a very exciting and value-added piece of anatomical software called Anatomy, I believe it's Anatomy 2.0. And what happens with this is you're able to, in the courtroom or in a deposition, the expert can peel away the layers of the anatomy, both the muscular layers all the way down to the bone, through the nerves, through the vessels, and really put a very permanent imprint of what an injury, what a soft tissue injury in particular can entail. And they are much more intricate and complex, as you'll find out, than the term soft, which everybody thinks soft tissue, soft, it's an easy thing. It should be 4 to 6 weeks of care and everybody gets better. But in fact, it's quite different. Dr. Sam then will take a deep dive into the in-office exercise rehab world. He'll discuss and demonstrate what your clients, our patients, go through, an experience from their initial education and how they can participate in their care from start to finish. Dr. Taylor will then demonstrate a virtual chiropractic PT visit. We've done hundreds of these throughout the pandemic. Not only on the medical side where we've done medical E&M visits, but we've provided virtual chiropractic and physical therapy and exercise oversight visits for those patients that may be shuttered in the house for whatever reason regarding this pandemic. Dr. B will then go through the software we talked about earlier. Don't go away from this program. You want to see that. And then Dr. Taylor will finish with something that's been on our minds quite a bit over the past several years, how to perform vestibular and cognitive therapy for patients that have had moderate to mild traumatic brain injury, concussion, and post-traumatic stress disorder. Multi-specialty does have a neurotrauma institute and has been in place for the past 4 years, and we've been very sensitive and of these types of conditions that may not be the primary complaint as the patient client comes in to see us. They've got neck pain, they've got shoulder pain, they've got back pain. But then these subtle neurological changes, memory loss, dizziness, forgetfulness, irritability, those types of things, the constant headache that might indicate that there's been a mild to moderate TBI post-concussion problem. And if these things are taken care of early and conservatively, most of these types of problems will get better. But the patient needs to know that they will get better. There's a psychosocial component, there's a psychiatric component in virtually 100% of the TBI cases. But enough of that. Those are the goals for today. As Mr. Feldman said, when you have questions, go ahead and put them in. He will be monitoring those questions, and as time allows, and I think we've been given some generous time here today, we'll be able to answer as many questions as possible. So with that, let's get started. And I present to you Dr. James Beecham, and take it away, Dr. B. Thank you very much, all of you, for being here.
Thanks, Dr. Thorne. Appreciate the intro. Yeah, I'm Dr. James Beecham. I've been in practice about 32 years now. Graduated top of my class, Life West, 1988, I think during the Reagan administration. So it's been a little while. I've done a few therapies over the years. And I'm going to be talking to you today about muscle stimulation, ice, and heat, the good old 97010 and 97014 codes, which I know when you review records and you're looking through our therapy notes are grindingly boring. I mean, it's like heat and muscle stim, heat and muscle stim, heat and muscle stim, 20, 30 times. It's like, really, how come this goes on for so long? What's going on here? Why can't people just do this at home? So in order to understand what's happening in the therapeutic process, you have to understand what's happening in the injury process. So let's take a broken bone, for instance. If you break a bone, you're going to be in a cast for 8, 10 weeks, something like that, depending on the severity of the fracture. Why? Why immobilize a broken bone? Because it's not supposed to bend. It's supposed to be an immobile, strong structure, so you have to immobilize it until it heals. Now, back in the old days, before X-ray, when you would leave a cast on a broken bone too long, you would get something called cast disease. And cast disease is when they take the cast off and the fracture is fixed, but the elbow no longer bends. So you get out and you're permanently stuck in one position because they left the cast on too long. Why would the elbow freeze up when left in a cast too long? Well, it just goes back to the simple adage, if you don't use it, you're going to lose it. So if you immobilize soft tissue injuries, or even uninjured soft tissues, they will almost immediately start to tighten up and fuse. So when you have a sprain and strain injury, you do the opposite of what you do with a fracture. You have to get it moving again. Now, there's several things that happen, and this explains the passive modalities in the process of the injury. In acute injury, you're going to have microscopic and sometimes larger tearing of the ligaments, the muscles, and the soft tissues. You're going to get swelling, you're going to get inflammation, all these chemical reactions. What's the right therapy for that? Everybody knows for an acute injury, you apply ice. Patients can do ice at home, and we often give them ice packs and instructions on home ice because it's safer than starting them on heat right away. But if I get the patient in the inflamed stage, we're going to put ice on them in the office as well, because we're also going to be doing other movement type of therapies with them, and we want to control the inflammation in the fresh injury. So you've got these tears and microscopic tears in muscles cause a lot of spasticity and a lot of pain. Once the swelling starts to go down, the spasm is going to prevent adequate blood flow through the muscle. And you're going to end up with a situation where you have what we call tissue ischemia. And that just means low oxygen content of the tissue. It's just like when you're doing cardio and you get the burn, and you're starting to feel that burn and you stop and it kind of goes away. Well, you're getting the burn because that's the feeling of hypoxia, of lack of oxygen flow in the muscle. With a muscle spasm because of a tear, it's not going to stop because the lack of oxygen flow makes the spasm worse, which perpetuates the lack of blood flow, which then makes it even less oxygen. And you have this nasty, vicious cycle, which can honestly go on almost indefinitely. Because of this virus situation, I had 2 patients come in not too long ago who had had no treatment for 2 months. They had been basically resting and applying home heat and ice, and they were a mess. They're doing great now. They're starting to make some progress because we're doing therapeutic levels of heat in the office. Because what we're doing with heat is we're intervening with the patient's injury physiology using our temperature regulation physiology. So if you take a hot pack, with enough intensity of heat for a long enough period of time, and you place it on an injured area, the body's going to think that area is overheating, because it is, and it's going to rush blood flow specifically to that area. Well, we're putting the hot pack on top of the muscle spasm because we want better blood flow. The body will accommodate us in an attempt to move the heat away by pumping more blood through the area. And so as the blood flow starts to move through the area, the oxygen levels come up, you bring nutrients into the body, you almost immediately have a reduction in spasm. I very often have patients go from, say, an 8 level of intensity pain when they come in, and just with the heat will drop down to 4 or 5. And so what you're doing over the time period that the body's laying down these tissues is you're basically watering the garden of their injury. The body has to regrow meat. It has to regrow blood vessels. It has to regrow ligaments and tendons. And depending on the nature of the tissue, it takes varying amounts of time for them to heal. A simple muscle strain might heal in 4 weeks if you're lucky, but most of the time, let's say with a whiplash injury, car accident, somebody's rear-ended from behind, they've got some capsular damage in the ligaments of the joints of the neck, they've got some sprained muscles, some strained muscles and tears like that. You're really looking at more like an 8 to 12 week time frame to really lay down the repair tissues. It's no different than if you had a large laceration on your leg. It's going to bleed, right? That's the acute phase when you have to apply ice. Then it's going to scab, and that's the initial scar tissue formation starting to get deposited. And then it's going to start tightening up. And they say, don't pick it, or you'll make it bleed again. And what that refers to is what Dr. Sam's going to do, and that's reintroducing motion into the area. Because unlike a cast, we don't want to immobilize, we want to start to mobilize. Now, Dr. Sam's going to cover that, but for our purposes, we're going to focus on the heating element. Now, home heat is great, and we give patients little home heat pads to take home. But it's really easy to make the injury worse if the heat's too intense. You have to give them something to take home and something to do at home that will give them some mild relief, but won't cause increased inflammation or the possibility that they may burn themselves. So we give them that type of thing, and it's okay. But compared to what we do in the office, it's not even remotely close. Same ballpark, different league entirely. We're major league with the kind of heat that we use here because our hot packs that we use are 160 to 170 degrees in temperature, and they're very, very dense and saturated with water, so they have a strong steam component and a lot of thermal energy in them. They're not going to cool off real fast. They're going to stay pretty hot. So with that kind of temperature level, you have to realize a hot tub is only 100 degrees, so hotter than a hot tub, to coin a phrase. But also 140 degrees, you're going to get a third-degree burn in just a few seconds of contact with that. So we're running at 160 degrees for about 20 minutes. And the goal here, the reason we're using that is to ramp up the heat inside the body to cause it to really be aggressive with its blood flow increase. And then we need to hold it at that level long enough for the tissue to just be washed like a deep watering of your garden, like we've had this spring. The gardens are doing great. People are having a hard time, but the gardens are great because we've had so much rain, it's really saturated the ground. And we want to saturate the spasmed muscle with nutrients, oxygen, amino acids, and all the things the body needs to regrow these tissues. And that's going to take 8 to 12 weeks. And that's how come when the patient comes in, visit after visit after visit. I mean, it seems just like, oh, it just never ends. And the patient's thinking the same thing. But we just have to comfort them. We tell them, look, this is going to take a while. You're growing new tissue. It's going to be a minute. So, hang in there. You're going to have good and bad days. And honestly, we taper off on the passive modalities as the patient's tissues begin to heal, the spasm levels reduce, and Dr. Sam's techniques begin to kick in, where you retrain basic injured muscles to perform like they used to. Because we're looking at functional healing. You cast a fracture so it resumes its function of immobility. You move soft tissue so it resumes its function of mobility. And if you don't, you're going to lose mobility and you're going to have bad outcomes, like the 2 patients that I just recently saw the other day. So I'm going to try a little magic here. I'm going to share a little content, show you a picture of our hot pack and one of our CAs applying it. Here we go. All right, it's going to start up here. There you go. So let's go into my photos. Now, you'll notice my screenshot. This is the confluence of biomechanics. I like to work on cars, and the Terminator works that metaphor for me. So This is Charnice and Kaylin. They are my CAs. All of our CAs are trained with about 500 hours of in-office and classroom training. Every time that we apply a hot pack, and this is why it has to be done in the office. One, the intensity of the heat. Two, patient placement. You have to know how to place the patient so that they will not burn themselves, and you'll get adequate contact in the way you want. For instance, if you lay a heating pad on the ground and you lay on top of it like you would at home, now check out that steam. She's going to move to the side, and I'd like you to notice how she handles the hot pack. You can't touch it, not even with little rubber gloves. That thing is literally steaming hot, and she's making that point. They're constantly kept at a high temperature. I calculated we probably spend about $50 a day keeping those things hot, each machine. So she wraps it in very thick layers of terry cloth towel. She's indicating here that we've got 3 solid layers plus the towel, placing on the low back to get that penetration of heat directly in there. Doesn't look like much, but you can't do it at home. It's just not the same. So that is our use of hot packs in the office. Now I'm going to come back here. There we go. So that's how we apply the hot pack. Why can't you do it at home? Well, you can. Yeah, I'm not going to charge you to do it at home. I'm going to tell you how to do it at home, but there's no way I'm going to tell you how to put a 160-degree hot pack on you at home, because you will burn yourself. I've had patients burn themselves on ice after explicit instructions. I had 2 gentlemen last year peel the skin right off. Did exactly the opposite of what I said. One guy fell asleep on it. So you gotta accommodate for that sort of thing. So ice and heat. Why not home heat? Well, you just can't get a hot enough hot pack. You can't get the volume of heat. You can't get the positioning right, and it's too risky as far as the patient getting burned. In office, you're going to have a nice harvest of connective tissue and regrown muscle stuff by continuing to nourish those torn and slowly healing tendons, ligaments, and muscles. Now, I had mentioned that a torn muscle likes to go into spasm. Part of what happens with the tears is because you have tears, the body senses the weakness of the muscle. Now, pain is going to immediately cause a spasm, because if you hurt yourself, you're gonna clench up and try and hold it tight. But it will also just spasm in general, because a weak muscle will usually do that. So electrotherapy is a fascinating treatment that we use to help to relieve spasms in addition to the heat. So with electrotherapy, I have a machine. I'm going to take you over and show it to you while I continue to talk. My electrotherapy machine, this is the panel right here. Now you'll notice all these buttons. It's got about 8 or 9 different kind of combinations that I can put together of these characteristics like wavelength, pulse intensity, polarity, and positioning to give me about 16 different therapies, somewhere around 9 for pain relief, 4 or 5 for edema and swelling and control, and some even for muscle rehabilitation. So this is a pretty complicated machine, but you'll notice nowhere on it does it have TENS unit. And I will tell you why it doesn't have a TENS unit on it when I come back here. Oh, there we go. The reason why is because this is what powers the TENS unit. It's a 9-volt battery. It has a little bit of power, but I wouldn't hesitate to touch it to my finger underwater, because I'm not worried about what a 9-volt battery is going to do. What my machine does is it plugs into a wall, and I am not going to stick my finger in a wall socket, because you're looking at qualitatively different levels of intensity in terms of the electrical therapy. It is, again, too dangerous to use a lot of these electrical therapies at home versus a TENS unit. Now, a cynic might say that a TENS unit is a product liabilities lawyer's dream modality, because it's as unlikely to hurt somebody as it is unlikely to really help them. And in a way, that's true, but it can provide the patient with some pain relief. And that's the main thing we're shooting for with the TENS unit. The therapy that we're doing in this office is qualitatively and quantitatively different than anything that you could achieve at home. So we will often apply the electrotherapy in conjunction with either the hot pack or the cold pack. Typically, we use it until it's no longer needed. But as I said before, it's going to take 8 to 12 weeks of treatment to get the spasm levels down low enough that we no longer need these ancillary therapies. As we taper that down, Dr. Sam, who you'll see, is going to be ramping up the exercise component, because again, we're shooting for physiologic treatment with early intervention, not home rest. All the standards of care, 2 or 3 days of home rest, that's it. Then you got to start moving again, because if you don't, you're going to end up with some long-term increased pain and some problematic outcomes. And we don't want that for your clients or our patients. We want them to get better. We want to get them better rapidly. And sometimes we have to teach them how to hang in there. So when you look at the end result with all those codes, all that time, it is not a reflection of the clinical reality and the intricacies of the soft tissue healing process that the body has to go through. And patients and juries and people that I've explained this to, they get it intuitively. You know, you have to get moving again. You have to get the spasms calmed down, and you can get some really good results. And even if you end up with a situation where you need surgery, if you haven't done all the prep work beforehand, then the surgery is not going to go well. So it's a win-win in terms of using passive therapies for pain control as you rehabilitate a patient with these soft tissue injuries. It takes 8 to 12 weeks. You need some expert guidance on how to do it, and that's what we do. So that's it for me.
Thanks, Dr. B. One thing I will mention, I wasn't able to see the eStim device you had on camera. Could you potentially share your screen and show us your device?
Absolutely. I'm sorry about that. Let me
And then we'll
swing
move
back
on.
over there. Can you, there we go. Can you hear me?
Yes, yes.
Okay,
we can hear
great,
you.
great. All right, can you see my home screen?
Yes, there you go.
There we go.
Okay, we got
So
it
just
now.
to take a closer look, yeah, these are the all the different types. We've got interferential, pre-mod, Russian, high volt, micro, and all of the different wavelength parameters, memorized parameters, all of which my CAs have been trained to utilize, as I noted, with hundreds of hours of training. They do a fantastic job. They are in attendance with the patient the entire time they're on therapy. We have, as you'll notice from the previous picture, curtains in our office. And the reason we have curtains is because, there we go. There we go. The reason we have curtains back there is because we're no more than feet away from the patient the entire time they're receiving heat and the entire time they're on the muscle stimulation, monitoring their progress. They're my eyes and ears. They're always in attendance. And we tell the patients, you have curtains, not doors. Holler if you're uncomfortable. Let us know there's a problem. And we're constantly working back and forth and collaborating on the patients. I'll tell them where to do it, put the high volt on the trap with a hot pack and the rhomboid as well. I throw out the technical jargon, which is reflected in my clinical notes, and they know what to do. They've been very well trained, and honestly, I couldn't do it without them. Thanks, Doc.
Thank you, Dr. Beecham. Okay, now we'll move into Dr. Sam, who will take a deep dive into the in-office exercise rehab program. So go ahead, Doc, you're on.
Disable, there we go. Hello, I have to disable the video. To start, it won't let it happen.
It's okay, take your time.
It should say start my video, Dr. Sam.
It's coming up as start video and there's a slash and it won't let, it says the host won't let us do it. Is that,
There you are.
okay.
There
You're
you go.
live.
We see you and Luann.
Okay. We'll just switch me to there. Hello, everybody. Welcome and thank you. I apologize for the technical glitch. I'm Dr. Sam, and I'm going to go through a thumbnail sketch of exercise and what we do here at the office. And thank you, Dr. B, for sharing a lot of great information. I want to kind of pick up where he left off and explain when we see a patient, first and foremost, they have to understand what the injury is, the mechanism of injury, and how we heal that injury. That way they work together with me as a team, with my CAs and our staff, because they have to take an active role in rehabilitating their damaged tissue. With injury, as Dr. B said, we don't immobilize. Rest means rest, not immobilization. So when tissues are sore and painful, of course, we're going to rest them. But our primary goal is challenge the comfort zone to grow the comfort zone from day one. And even in surgical procedures in the hospital, if someone has a disc surgery, they get them up and moving around immediately. They don't want them to sit for days or weeks because it is soft tissue. So I just want to touch a thumbnail sketch on soft tissue injury, and then we're going to show you a bunch of exercises that we do initially, and as the patient grows their strength, then we can be more aggressive with those exercises. I also like to share that, you know, you can't go on YouTube and do this stuff, or online, and there's tons of information out there. And information, a little bit of information sometimes to a patient can be dangerous because they don't use it in the proper context. What we do here, and the knowledge that many of my colleagues have, is we use that information, we turn into knowledge. And when you can take knowledge, what makes knowledge into wisdom is when you can take that useful information, form it into a tool that is effective to achieve an outcome. And that's what we do here. We use our wisdom to take traumatized tissue and repair it. And we guide the patient through those episodes where symptoms wax and wane. They come and they go. There's good days, there's bad days. And we know that that's going to be there. We give them that all up front, so they know they're going to transition. It's a marathon in a lot of these injuries, not a sprint. And we're talking soft tissue. Sometimes there's tears. It can be a pre-op therapy to a post-op therapy. The more we do pre-op, the better they do post-op. With disc involvement, again, the criteria changes. This is not stuff you can just access simply on a website and think you're going to self-treat. So we take the patient through the exam, identify what the problems are, let them know, and then we go from there. So I use a simple criteria. When the patient first comes in with an injury, we show them their muscle chart and where their muscles are. And all these muscles, generally, I'm just showing you they're made of fibers. And those fibers bend and move. And to simplify, when you get in an accident, they tear and bruise. And when they tear and bruise from the inside out, you're going to swell, stiffen, and muscle guard. The body's path of least resistance is to do the minimum. In other words, guard and don't move, which we don't want to do because we want to restore structural integrity as quickly as possible. And pain is the ultimate modifier. If it hurts, the patient's not going to deal with it. Sometimes they'll try to take medication to get through the day, which is okay, but it's not going to heal it. It's going to mask the symptom. So when we get spasm and symptomatology that causes motion to be limited, and also the muscles in the neck and back attached to the spine, and that'll take the normal x-ray we have as a curve of 40-degree arch. Typically, when after the accident, I'll see a complete straightening of the spine. If we don't fix this, within 3 to 6 months of letting it go, compression can cause decay and degeneration, forming a bone spur. And within a year, they can have multiple levels of decay and degeneration. I've had a patient 21 years old with a bone spur this big. She was a dental assistant for 3 years and then presented with day one after an accident with a spur that big. So those things can happen. We know how to address them and correct that curvature to slow or stop any pre-existing problems and to correct any initial problems that are acute that can be resolved without causing decay and degeneration. The vertebrae line up, as I have a spine here, full spine, and you can see the green light here, that's normal nerve flow. However, when the patient gets in the accident, that spasm is going to cause the vertebrae to pull out of position, causing twist, torque, and compression that agitates the nerve, causing pain. The medication will help mask that pain and give the patient relief, but when it wears off, it's still there. When we do our muscle work and our therapy and combined with our adjustments, we make sure we restore structural integrity to the spine, nerve, and muscle components. Our goals are, number one, the patient, we want to restore full motion, full strength, full endurance. That's our goals. Now, I didn't mention pain there. Of course, we empathize with our patient, your client. These people are in physical pain and physical distress. We want to help them rehabilitate, but I let them know up front there is going to be some pain in the transition. When they understand that, they're more accessible to doing the work. However, we challenge the comfort zone to grow it. We don't push through it. It isn't the in the gym mentality of no pain, no gain. And nobody goes to the gym 10 hours on Monday and they're in shape Tuesday. So it just doesn't work that way. As we transition this, we build this program. So when patients are taught an exercise, they have to be supervised. I have some videos we'll get to later when I just had a few exercises I'll share with you that we did with one of our office reps. But even going through the video prior and then having her do the exercises, there still were tweaks and flaws that I could pick out. So nobody is absolutely proficient when you show them an exercise on one visit. If anyone golfs out there or plays tennis, you know you had a golf lesson and then you go golf on your own. You're like, why is my swing going crazy? you have to work and practice on that swing. Just like our patients work and practice their exercises, we supervise that. And we make sure that they're working and practicing whatever the exercise is proficiently. So we will start with some of the exercises today. I want to switch back over and show you an occipital float that we use for the neck to help build that up. As I go to sharing my screen here a second, we will show you how we build the curve gently and non-traumatically as we do this on this here. So we want to show you this here. Good. Exercise is an occipital float. We're going to show how to build strength back into the neck as well as repair and correct cervical lordosis. I'm going to have the patient, Lisa, so kind to lay back. And as she does, she'll lay on the float, and with her head, our heads usually weigh about 10 pounds. Now her head's going to feel like it weighs 0. As she rests on here, she'll gently just lift her chin up. And as she does, the weight of the back of the head presses into the ball, and the ball pushes in the curve. She holds 5 seconds, then we turn to the left, look straight up. We hold 1, 2, 3, 4, 5. Back to neutral, then we turn to the right. We look up 1. You can see the ball pushing into the curve of her neck. This helps us regenerate and help grow the curves and start transitioning from day one. Again, it's gentle movements. The patient, if they have pain in 1 or 2 degrees, they stop. And this is, there's no contraindication if people have pre-existing cervical fusion. The bones are fused, not the muscles, and that helps us work that out, and we can move on to the next session. So once they get more strength in the neck, then we build from there. Let's go back to me. And stop the broadcast. And that was our neck area. Everybody get to see that? Just want to make sure it showed up. Yes, Dr. Swan mentioned. Okay, so we next we're going to move on to the.
You got it. We saw it, Sam. Go ahead.
Next is shoulder. Again, any injury to the patient, we're going to go over anatomy. Dr. Beecham has a lot more information later on in the seminar where he'll be able to address the layering we talked about that's available for testimony. This I just generally point out to the patients. Normal rotator cuff. When they come down and they get in an accident, there can be possible tears, partial thickness or full thickness, and some of them end up resulting in therapy and surgery. So when we see damage to the shoulder, remember the car accident, they'll grab the wheel a lot of times if it's the driver and hit the brake, and that impact turns and jolts back into that cavity. When this humerus hits into that joint capsule, it swells up. The subacromial bursa can swell. Patient has what we call impingement syndrome. They won't be able to raise their arm above halfway, or maybe even a quarter of the way. So normally, of course, we can raise our arm all the way up. Again, your client, our patient, they want to get back to work. How long is this going to take? And how much do I got to go through it? Or is it fixable, first of all? And when we have the accessibility to do the x-rays, make sure we have an MRI if they need be, and then we can quantify and qualitate that care as the symptoms wax and wane. So many times with partial thickness tears, through therapy, they heal non-surgically. And if there is full thickness tears, we want to make sure the muscles around that full tear stay strong and do not atrophy so that they can do better post-operatively. So those are decisions made by the surgeons and the patient when they get to it. As the therapy department, we guide through those, okay? So I'm going to show you our first exercise with the shoulder that may be not even able to move off of their lap. I'll have the patient in the seated position. They may just be able to get their arm on here to start, and we gently have them just straighten their elbow. Sometimes it may take me 1 or 2 days just to be able to get the patient to straighten their elbow because they've been guarding it so closely to their body. As we
Sam, excuse me, that's about 10 minutes, just letting you know.
So as they straighten that out to bend, middle, and down, this will be a way we can help that motion start. Once they develop that full flexibility in this position here, then we start working on above the head motion as well. So I'm going to show you a video with a pulley, and that's another way we can help here as we share the screen, and we'll go to here, start broadcast, 2, 1, and we'll go to pulley, and we'll go to pulley on here. Overhead pulley motion. We're now in this position with hands in front of the face. We're working on getting motion in the rotator cuff above the head. Patient will exercise the right shoulder here by pulling down with the left hand and letting the right hand go up, just to the point of pain and then back down. This patient has good motion. As they go forward again, we do 10 of these, and she's pulling with the left hand, just letting the right arm go up for the ride. As they become more healed. And that motion helps break adhesion and improve the joint capsule. It's a great little stretch. There are home pulleys that can be just prescribed for home exercise, but we make sure techniques are correct before they can do any of that. Also, I could show TheraBand here is we give the patient a
external
TheraBand
rotation exercises of the shoulder rotator cuff.
Excuse me. There's different colored TheraBands. She has a yellow TheraBand here. And when she starts, you can see her hand was a little bit turned up. We just fixed that straight to make sure it's good. It has to be at 90. We put the towel under the elbow to keep that contacted to the ribs. And as she goes into external rotation, this works that supraspinatus muscle. Now, when there's just bruising, you have to get strengthening in there. Combined with the lap roll helps motion and flexibility to get motion, strength, and endurance. All of them help bring blood flow to the area and benefit it in both ways, both strength and motion. So you'll see if she's doing it properly, the towel stays put. If there's an improper motion, you'll notice her elbow will pull away from the body and then the towel will drop. This gives the patient an idea too that they're doing it incorrectly, and then we can see where they're at. Okay.
That's how we do with home exercise.
I'll go back to me, live, and stop, and tap. Okay. That way, I want to show you just the knee exercise or low back, and we get into disc and fall. We use a lot of exercise balls here for the knee. If they can't walk on their knee, we start them with just a gentle transfer weight from heel to toe. That mobility helps them start getting motion in the knee, as well as the ankle, knee, hip, and thigh. If there's pain when they walk, they're going to have a limp. They can't even put full weight bearing on there. But when you sit on the ball, and they can hold on if they have to, but half their weight now is above, half's below. That way there's less pressure on the knee, and they can start simulating walking without really walking. As we get that motion to improve, then we work on circular motion back and forth just to get that flexibility there. As they get more strength, of course, we can work at stationary bike and exercises. But I want to show you a couple of things. We just start for the lower back. Tons of exercises are out there on the web. When your lower back hurts, we start them in a seated position because people that have to drive or sit at a desk all day need to be able to sit at work. They can't lay down or they can't stand up. So in a seated position, we start them with just a gentle pelvic tilt motion side to side. As we sit on these bones, all the pressure is pushing on the back, but on the ball, the legs take some tension off of the disc, and we allow that motion to get movement in the disc and the muscle area. And then we work on just small circular motions because we want that proper curve of the back. Like we mentioned earlier in the neck, proper curve, proper alignment. These exercises are done in addition to the modalities Dr. B mentioned earlier, and then we do our spinal adjustments. Okay. I also mentioned muscles, how they damage. And I finally just want to say with the disc, if you press a balloon and twist it, it's going to bulge. If you take the pressure off, it goes back. When discs bulge in our bodies, there's annular fibers that hold them in. They become torn. They take longer to heal than just a muscle or ligament. As we do these motions on the ball or with the float, it gets circulation blood flow not only to the muscle, but also to the disc. And this way it helps that heal, but it's going to require a longer treatment period. And so with that, I know I'm limited on time. I wanted to just give you a thumbnail sketch of what we do here. And I know I had a certain amount of time. I probably went over that, but there's so much more to share. And we may do it additionally down the road. But I want to thank everyone for their time and their interest. And of course, I think we're available at the end to answer questions. Thank you.
Let's talk to Thorne there.
Well done, Dr. Sam. Thank you very much. And now we're going to move to Dr. Taylor, Jessica Taylor. Well, she's going to demonstrate a virtual chiropractic PT visit through a program called MEND. Jessica, you're.
All right, good afternoon, everyone. So as Dr. Sam just went over the exercises that are taught in the office, but what is the patient doing at home. So this is where the home exercises come into play. It is a time-based code, either 5, 10, 15 minutes. How much time is spent usually depends on several factors, one being how many areas does the patient have, or how well they're even picking up. Some patients pick up exercise better than others, especially if they've had an injury before. They're usually more familiar. So there's just those types of things that go into what code we particularly use. Everything documented. I'm sure if you've seen have any clients that treat with us, we use a home exercise form because I, myself, and many of the other doctors, we give handouts to the patients. Because if you just go over it one time with someone, they're not gonna remember. Also, that factors into the concussion. They might not remember the exercises you just taught them. So handouts are given to the patients. We have them sign a home exercise form that acknowledges they were given these sheets to do at home. Usually this is done in a face-to-face with the chiropractor in the office, but now with everything that's going on, we are having to do things virtually and get, like Dr. Beecham said, Dr. B, get a little bit more technical savvy. So there's a program called HEP to go, and I'm going to go ahead and bring up a sample of it here. With HEP to go, it's an online platform that has thousands of pictures where I can go and create different programs through going through the different phases of rehabilitation. So here's a simple sample here. You can see there's thousands of pictures. There is all the different areas. It even takes you through different the phases of rehab, where you can do range of motion, then you can build into strengthening, even some more active sports specific type exercises. And so I have gone on here, many other doctors as well, and we've already made different programs. And if the patient cannot come into the office, I can take this program and I can actually send it to them either with just basic information, either via text or email. The exercises are very specific, tells the patient how many times to do it, how long to hold it, the sets, how many times a day. It even has videos that the patients can access virtually as well if they still have some questions and they're not in the office. So down at the bottom of the screen here, I just plug in the patient's phone number. They will get a text message where they can access the routines given. You can see by the options there, you can choose how many weeks it is good for. I usually give around the 2-week time because you just don't want to do the same thing over and over again. That's not how somebody gets better. You have to continually challenge the body to make improvements. You know, starting range of motion, getting it strengthening, just like Dr. Sam went for, and then we can print these and keep them in the patient's chart. So now I'll just move on. So say I had given a patient can't come in the office, so I'm going to do a telehealth visit. So this is the MEND platform, new technology that we're using to treat patients. So the provider can go on or any of the provider staff can do it, and you'll see the appointments that you have for that particular day. The patient will also have a dashboard that is similar to this, and they will get reminders on their smartphone that they have an upcoming appointment. These are HIPAA compliant. Even forms can be signed and sent over this software. So I just did all this pre-recorded because, you know, sometimes technical glitches can happen. So as you see, it says where I can continue the visit. And luckily my younger brother, who is a certified chiropractic assistant with the company, was nice enough to help me begin with this. So he just wasn't on his end, he wasn't available yet. But as you now see, he comes
Well, hello there, Cody.
Hello.
Did you get the exercises that I sent you?
I did.
I'd just like to demonstrate with you. So could you show me how you would do the upper trapezius?
So I sent Cody just a simple home exercise routine for the cervical spine. So if I was doing this with a patient, I would do it the same way. I would ask them to demonstrate an exercise for me. And this is where it is important to do these kind of visits, because if the patient is not doing the exercises correctly, they can actually do more harm to themselves than good. And a lot of people will just assume that they know how to do something, and yet when I go and have them do it, they are doing it wrong. And just like Dr. Sam mentioned, you know, he had to tweak her hand because she wasn't doing the exercise properly.
Stretch.
Sure.
So here he's demonstrating the upper trap stretch for me.
Excellent. And always want to stretch to the point of pain, not past it. Now demonstrate for me the suboccipital stretch. Okay. So when you're doing that stretch, you actually want to press your chin in towards and pull your head forward to feel the stretch at the base of your skull. Much better.
Yeah, so as you can see, I may actually had him do it wrong, so that way I could demonstrate for you guys how a real visit will go. And that's how I would do it with a patient as well, if they were doing the exercise wrong. And then the patient, I don't know if you could see, but in the top corner is where you can see me. I'm on the call as well. So the patient, if I wasn't holding my cell phone videoing that whole routine, the patient would be able to see me do it too and be able to mimic what I do, because people learn different ways. So the visit is the same as if they were in the office. We're just doing this virtually. They're still getting this one-on-one time with the doctor. So that's why we were able to charge for these types of therapies, but also obviously doing it time-based and with the proper documentation. So that's all I have for the HEP to go and men. So I'll turn it back over to Dr. Thorne.
Thank you, Doc. Couple of points here before we move on into the software piece. It's very, very important to get our patients, your clients, into care for these types of post-traumatic injuries very early and very active. And I think you've seen some of that occur here. Some of the pitfalls, or maybe the challenges where one of your clients may have to testify or go into a deposition are some of these exercises appear sometimes to look very subtle to the untrained eye, and sometimes your patients or your clients may not adequately know how to explain that they're actually going through exercise. A lot of the lay people think, well, exercise, you go to a gym, you pick up some dumbbells, you run on a treadmill, you jump in a pool, whatever it may be. So patient education, very, very important. And for them to be able to understand that early on in the care, some of these motions, there may not be a tremendous amount of resistance, and there may be, as you saw Dr. Sam sit on that physio ball, if you've ever had the opportunity to do that, he makes it look easy. And some of these exercises, these folks make look easy. And for the injured victim, that can be something quite different. So please be aware of that. Make sure, obviously, your clients are prepared for their testimony, because many times we hear that a district court judge may ask a claimant, what type of exercises, or what did the doctor do? And the patient would say, well, he put a heating pad on my back, or she, shocked me a little bit, and I don't really remember doing many exercises. And then they cracked my neck and I heard this thing, and that was it. And so, a judge who also is a lay person with regard to these things, and many of the bench, many of the district court judges may not have background in personal injury. They may have come out of the prosecutor's office or just from some other area of law and been a political appointment, as you know. So, education is critical. We are able to testify, and we want to testify in those cases you may specially set. We think that there's been somewhat of a disconnect with the 10104s, and we understand why the courts are using 10104s and have been for many, many years. But hopefully some of this information will allow you all to be able to relate to the court what your claimants and what your clients are going through. Another thing I want to point out before we get into the anatomy software is the concept of soft tissue. We talked about it earlier, and I'll just be brief here, but if you can think of any type of body tissue, whether it be muscle, ligament, tendon, fascia, the outer layer of your skin, blood vessels, nerve tissue, your brain, all of these things I've mentioned, by the way, are soft tissue. The only thing that is not a soft tissue in your body is a bone. And strangely enough, a fracture many times will heal almost perfectly. Although there is value in a fracture and documenting a fracture, a lot of times the soft tissue issues are pushed off to the side. And I want to express to you these soft tissues are the very essence of life, from the nerve tissue to the muscle to the ligament to the support of these joints and ultimately to the biomechanics. So mechanism of injury is critical. Many of these injuries are dynamic. They wax and wane in their symptoms. So, one day a patient may say their pain levels are 2, the next day they may be 8, and then one day they may come and say, I feel pretty good today. And if that happens to be in the documentation, if you're on the other side or the defense side, they're gonna point that out and say, well, doctor, this day, Miss Jones said she didn't have any pain. So why should we do it? She must have been better. Why should we do anything after that? So it's important to understand the dynamics of these post-traumatic injuries and be able to explain them a little bit more, not only to educate your client, and we're happy to do that. We think it's important when you have that case you want to specially set, you've got a good client, you've got clear liability, and the issue might be utilization of care. Maybe there was 3 months, 4 months of care, the bills seem high. There's generally a reason other than the doctor just wanted to run the bills up. So it's important to prepare your expert and to utilize our services when you can not only do what's best for your client in that representation, but also educate the bench for the future. And so we think judiciously choosing when to bring in an expert is critical in creating value in your case. The other point I want to make here is there's a great literature review, and one of the symptoms that come across in all of these research studies that indicate a poor prognosis, believe it or not, is intensity levels of pain early on. So when your client comes in and they're in excruciating pain and they need to relate those levels of pain to the doctor, and that which has been beaten like a dead horse as a subjective complaint, and couldn't a client say anything about their pain, and how do you really know how much pain they have? Yes, there is a subjective component to that, and doctors, our folks are trained to be able to sort out when somebody is symptom magnifying or hyper complaining, if you will, versus what is a true pain level, and utilizing things such as visual analog scales for pain, and utilizing our Westry disability indexes and duties under duress questionnaires and activities of daily living. All of these things that we present to our patients that allow them to express what their limitations are on a regular basis ultimately create, through the literature and through reference material, objective findings, in addition to your x-rays, to your clinical findings, to what may be a positive or negative MRI, etc. One other area that I'll bring up, and then we'll get into the anatomy, is don't forget when your client has a pre-existing condition. Many times we hear lawyers say, oh, the pre-existing condition, that kills me, or the defense says, well, it's all degenerative underlying problems, it can't be related. There are many, many studies that, and we take our patients as they come, apologize for that. And so many times, somebody that has an underlying condition is going to have a more complex recovery, even from a low impact, minor impact, low property damage claim. If they had a previous neck injury, or if there was some previous underlying degenerative changes that show up in an MRI, they may have been quiescent and made active. So many times value can be created in pre-existing or previous traumatic injuries. Very important. The victim that has been in a previous accident is 4 times as likely to undergo a more complex injury the second time they get hit or they become traumatized. Also, without sounding sexist, females versus males are twice as likely to have a more complex neck injury when they've been involved in one of these whiplash-associated disorders or cervical acceleration, deceleration injuries. Finally, with what Dr. Taylor showed us, understand these are specific CPT codes for telehealth. And I can tell you, as of April 20th of this year, Medicare has tripled the reimbursement for telemedicine codes, which indicates, as a result of probably this pandemic, how important telehealth becomes. And if a patient or client cannot make it to the doctors, it's important that you stress to them that they can still be treated. As you've seen here today, they can be taken care of medically, they can be taken care of from a rehabilitative standpoint, and they will thus have continuity of care, and there won't be those gaps in treatment. So with that all being said, we're going to go back to Dr. Beecham, and he's going to show you a fascinating piece of software that can be used very effectively, and he himself has used it effectively and gotten some very nice verdicts. So Dr. B, take it away.
Thank you, Dr. Thorne. Good to be back. I'm going to share my screen content, so please bear with me while I switch you over. I'm going to show the 3D anatomy program I used testifying last year. Do we have a good visual?
Yes.
We do. We have your...
Just double checking. All right, so let's go over. Now, this Terminator model is an interesting metaphor. All right, so this 3D program is quite fun. I'm going to reset this guy. Here we go. We're back to the start. When you see an anthropomorphic or a human-shaped figure, the mind automatically tries to identify with it. If it's in a comedic way, it will make something funny. But if it, like the Terminator analogy, if it's in a damaged way, it'll create a sense of horror, and it draws the person in. And I found that the juries in the last 2 cases I did last year had a very strong reaction to this. I wasn't as good working with it then as I am now, but the program is quite fascinating because you can get all of the musculoskeletal details all in one place, and you can layer them. Now, it also has organs and such that will be thrown on that you probably will not need. But for our purposes, since we're dealing with musculoskeletal injuries, we're going to peel the patient down to the bare essence. You can do this on the fly in front of the jury if you wish. Here's your baseline model showing the hard tissues. Dr. Thorne was saying hard tissues, generally speaking, they are easier to manage than a soft tissue injury because once they're fused and immobile, they're fused and immobile. But when you add connective tissues, now these connective tissues are called soft tissues, but when you get into looking at some of the detail, like of the strength of a hip joint, I can tell you from cadaver lab and dissecting human bodies that these tissues and these ligaments down here, particularly the ischial-tuberal, sacrotuberous ligaments, all of these ligaments are incredibly tough and durable. You will go through scalpel blades like paper clips. It's just, I don't know if that's a real metaphor, but these tissues are incredibly dense. So when patients are getting injured, they're getting injuries to treatments that have very poor blood supply. If we add the blood supply to the body, as just an example, you can see how richly innervated and vascularized the abdominal cavity is, and then the innervation moving down the legs. But what you'll notice is there's not a lot connecting to the connective tissues in these areas, these large ligaments, because they're structural. They're not heavily vascularized. They heal very slowly. I personally have had two ankle surgeries, and the doctor told me, he said, 14 months. 14 months, you're going to be cussing me. And he was right, because it hurt worse for 14 months, because these ligaments are very slow healing. So the whole 8 to 12 week time frame is for most repair, but ligaments will continue to heal for a significant amount of time. Now, I'm going to take the vascular system out, and let's start adding muscles to the spine. We're going to shrink our little fella down here. We're going to pivot around. You can identify with this program any particular area that has an injury for whatever we're working on. So your client may have a hip injury, and we may be wanting to look at deep hip musculature, bursa, pulled groin muscles, and such. With respect to the neck and shoulder, you can add muscles in, but I found it to be tedious in live court testimony to construct something like this on the fly, although it can be done, and it worked out extremely well, and the jury really did seem to enjoy it, and frankly, everybody was fascinated by it. Even the other opposing attorney was eyeballing it and said, "You got any questions?" She said, "I don't know what to even say." So what you could do to help yourself when a situation like this comes up and you want a good visual is you can pick and choose pre-done, pre-existing templates that highlight specifically your client and our patient's injuries. So if we strip off the deltoid muscle and we want to go into showing some particulars, let's take off the chest muscle too. If we want to show some of the particulars, this is in the way as well. There we go. We get in here, we can see the rotator cuff. I testified on a case last year that had a tear in the subscapularis muscle, this muscle right here, and he was a painter and he had to work overhead. Every time he raised his arm, he would get a pain in that area, and it showed up on the MRI almost exactly like you see it right here. And the other attorney said something to the effect of, "Well, it's just a little tiny bright spot." And I made the point that this little tiny bright spot represents scar tissue and damage and inflammation, about like an X-Acto knife being plunged into the muscle. And every time he sits down on the couch and he reaches with his right arm to put his arm around his wife, he can't do it because it hurts every time he tries. And we were kind of going at it a little bit at that point, and I think it had kind of a powerful effect. So I like setting up pre-existing templates to illustrate the different structures. I set this one up to illustrate muscle issues. Again, you can peel the muscles back, identify the muscles, especially if it's mentioned in an MRI report. You can directly correlate this to anything that may come up in imaging reports. So that was shoulder for muscles in general, but shoulders can also cause impingement of arteries going down the arm. And this can contribute to symptoms down the arm, which oftentimes mimic pinched nerves in the neck. And a lot of times you'll see a situation where somebody will order an MRI of the shoulder, and you'll find out in the end, oh, it was actually a problem with the neck after all. And the reason is because the symptoms overlap so much in this particular area. For example, if you look at the template that's showing the nerve flow down the arm, you'll see what a tangled web it is. Any kind of a whiplash injury, sprain and strain, hyperflexion, hyperextension is going to pull all of these muscles in this area. So this right here, when you snap that head back in a car accident and it's thrown like this, it's going to overstretch all of these. These muscles are all going to go into spasm, and you're going to end up with a patient with all kinds of crazy stuff going down the arm. Very, very, very common type of thing to see. And the program, this is not my computer, but the program allows you to make annotations on the fly as you're doing it, and as you see me doing it right here. Just to touch on the shoulder a little bit more, since I have a nice view here, we have the bicep tendon in this area coming through here. If you have somebody who's had a surgery, you could certainly delineate all of the different things that were operated on, including whatever particular rotator cuff muscle. Supraspinatus, for instance, is a very common muscle to end up needing surgery. It's a great example, and I want to use this with patients too. It's great to let them know what they're dealing with and the complexity of it. And it is not as clean cut and as simple as this, because there are no blank spaces, no empty spaces in the human body. If you start adding everything that's going on, it is an absolute mess of stuff that's happening inside the body. So this is a gross simplification, but it is a wonderful teaching tool. Another thing I worked on was we have a traumatic brain injury, sort of a focus in the practice. And one of the things it's difficult for patients to understand is that very similar symptoms can come from, say, a whiplash or a concussion. It's often very difficult to tell the difference because an injury to the neck in this area will affect all of these nerves traveling up the back of the skull. It can cause dizziness, it can cause nauseousness, it can cause visual disturbances and lack of focus. On the opposite end of things, their entrapment within the muscles can also cause very similar types of symptoms. Spasms, muscles are going to throw off the equilibrium because it's going to change the mechanics of the joints in the back of the neck. Every one of these joints knows exactly how big it's supposed to be, what position it should be in relation to the other joints as the body's going about its normal movement, including that joint where the skull sits right on the spine. If you have damage to the atlanto-occipital joint capsule on the left, and the body thinks that's in one position and the rest of these joints think that they're in another position, you're going to have disequilibrium. You're going to get dizziness. You can explain that to a jury by showing them that the input doesn't match. It's just like the check engine light coming on in your car. You're going to have a lack of computer matching sensors, and you're going to throw a code. Let's hope that the patient doesn't code in an accident, but if they do hit their head or they are jostled hard enough, you'll notice the space between the skull and the plates of the brain. You've got a significant little gap, and it's all filled with water. Well, not water, but it's CSF, cerebral spinal fluid. So the brain is sloshing around in a nice pool of water. You do not have to have head contact to shake the skull hard enough to bang it against the inside of the skull wall. So that is a non-head contact concussion or a mild traumatic brain injury. When you see it, it makes sense, but until you see it, it really doesn't. But if you want
a little over 10 minutes, Doc.
Thanks, Doc. As you go, as you can peel this away, show the different parts of the brain, areas that are affected. My second favorite area, we're almost done here. I like this one for a case that I used last year. I focused on the low back disc. Lumbar disc, very common injury. It's got the classic circular fibers that Dr. Sam was talking about, the gel center, which is actually like a thick paste. And when you have a bulging in the disc at this area, you will easily get compression, and I will show you why, because there is no room. Now, I'm not going to complain with the designer how he went about or she went about doing this, but there is very little room between the disc at L5 and any kind of degenerative or bulging situation going on here, because it's just snaking right through there. There's very, very little wiggle room. So you may see an MRI probe and say, well, it's just a mild disc protrusion or a mild disc bulge. It's like, yes, but it's correlated with the area of injury. And that is the thing that I always stress. You've got to be able to correlate this injury with these symptoms and this incident, particularly whether you do or don't have a history of former problem in the area. So I found it to be a great teaching tool, fascinating for patient education, great for your clients, and super, super good on the stand. Had real good results with it last year. Really enjoyed working at it, and we're getting better with it all the time. So I'm going to sign off here and try and get back on Zoom. All righty. Thanks for your attention.
Dr. Thorne, you're muted.
Sorry about that, folks. Okay, so just one quick comment before we take you home with Dr. Taylor's work with the TBI, vestibular and cognitive therapy. I think very, very critical to understand, as Dr. Beecham showed you, that these layers of muscle, ligament, tendon, etc., nerves overlap. So many times an accepted body part, for example, in a workers' comp case might be a neck or might individually be a shoulder, etc. And many times all of those areas overlapping, and we have to make sure that we take care of treating those areas, all of them. And sometimes the adjuster will come back or the defense attorney will come back and say, you know, that we're not going to pay these bills for the neck because it was a shoulder problem. We're not going to pay the bills for the upper back and shoulder, which was the accepted body part, and you're treating the neck. And there's very, very good reasons why we can document that, and still there are issues that come up, as you might well imagine. So very important when your clients are complaining of areas where there is anatomical overlap, they need to be aware that the doctor might actually find some things that don't seem to be very obvious, but very, very important to create a good outcome from a treatment perspective, and also make sure that the value of that case is maximized. So with that, we'll move to Dr. Taylor to show you the neurological work in the therapeutic rehabilitative setting.
All right, I'm back, everyone. So talking about, I could do a whole 2 hours alone just on concussion and the rehab and everything that goes into it, and maybe we could do a more specific one with just that then, but I'm going to just touch on the basic therapies that we use here in the office. We're finding that more and more now when people have car accidents or they fall and hit their head, or a construction worker has something fall on their head, we're beginning to get diagnosed with these TBIs, these traumatic brain injuries. And there's an infinite number of symptoms people can have, varying from memory loss, agitation, dizziness, blurred vision, affecting both cognitive functions, which we're incorporating memory, processing, focusing, multitasking, emotional, behavioral, and then getting into the vestibular side. This is your balance, how your eyes track, how your brain basically gets information from what your eyes see around you. So both these systems can be affected from a TBI. So a couple of things I want to be touched on is, how is a chiropractor qualified for treating a brain injury? Well, the brain is included in the central nervous system, and chiropractors are experts on the nervous system, both the central and the peripheral, which involves, like Dr. Beecham showed, how the nerves come out into the arms and down into the legs. Diagnosis is done looking at the mechanism of injury, what system, doing a thorough health history, which is part of our everyday normal exams. And then there are neurological tests that are done. Chiropractors go through a very rigorous and thorough educational program. We are a real doctor. We just treat the body naturally without using medications and drugs. We have to have 4 years of an undergraduate program, and then we have to go to 4 years of chiropractic school. Educational wise, we have the same amount of education hours that an MD does. We learn orthopedics, we learn neurology, radiology, sports medicine. We are licensed in our state by taking a state exam, and then we also have to do board exams. So I won't bore you anymore with that. We'll go into the cognitive therapy first. And I do have a demonstration. So we have this wonderful program now. It is called RehabCom, and it is a cognitive training software. It can do its own bit of testing. And normally we do 2 days worth of testing, and I have someone demonstrating here. He's working on a memory game. So he's having to look at pictures on the screen, memorize them, and he will then turn them over. Now it's basically just like a little memory game you played with your kids when they were younger, and he has to find, he didn't memorize them too well because he was, for purpose of demonstration, he was trying to move quickly. But this is just one of the many parts of this software that we can do. The software, like I said, does testing, and we do 2 days worth of testing, breaking it up into field of vision, memory, logical reasoning, all of the complex brain processes that can be affected by a TBI. This software does those particular tests because then they have certain exercises depending how the patient did testing wise on what areas they need to work on. Not everybody works, everybody's body's different. Not everybody's body works on the same thing. And this is something beautiful because it actually prints that out into a bar graph form. And it's something that we can physically present to a judge or jury and say, no, this person actually has a deficit in this. And then when he is done with the exercise, it will print out, it will show how his progression was. And did it continue? No. And then it will actually show how his progression was for that particular exercise. And I will stop the process. And it prints bar graphs out like this in color form that we can print and show a judge or jury. And then the testing is printed out in the same way. And I know it's backwards, you guys can't really see it, but it's something physical that we can show to them, not just what the patient told us. We have concrete physical findings that we can use. So then the other part of a concussion, we go more into the vestibular side. And I do have some demonstrations of those as well. But I was saying vestibular therapy, it's intended to alleviate both primary and secondary problems caused by a TBI. So after a comprehensive evaluation, you find out what specific problems the patients are having. And there's 3 different types of training that we can do. We can do habituation training. So this is used to treat symptoms of dizziness, especially when the patients will report that they have increased difficulty when doing quick head movements, or I bent down to pick something up, and when I stood up, the whole room was spinning. So basically, we have to get the patients used to doing these things again. And this definitely needs to be in an in-office setting so that I can monitor, so I can see if that person's starting to get dizzy. I can stop them, have them sit down so that they don't, in essence, fall out, pass out, and hurt themselves worse. So this is something that definitely needs to be monitored. And I have done this also monitoring a patient at home while they were doing vestibular therapy. I just made sure they were on their bed so that if they did fall, I wasn't there to catch them, but I could stop them and see that they were about to, and have her sit down safely until the symptoms passed. So I do have some. So the first habituation exercise, this is working, I was saying, on the quick head movements here. Again, my younger brother was kind enough to demonstrate. The service dog is doing a cameo appearance there. So this is focusing on an object about 6 feet away and doing those head movements. And we start with very slow head movements. He's allowed to blink as much as he needs to, because different people have different intensities with their symptoms. So we move very slow. We progress from sitting to standing. And then I'll play it again because it's so short. From sitting to standing. And then we can even do more complex movements where he then follows an object. His head stays still and he's following the object with his eyes, just like they do on DUI tests. So this is this habituation part. And then you also have gaze stabilization. So gaze stabilization, and this one I do have instructions that I'm giving him.
So the patient, Cody Taylor here, will keep his eyes and his head at the...
I think it's a little hard here. So basically this is called a slow saccades exercise. So there are 4 X's on the wall there. And gaze stabilization is used to control eye movement so vision can be clear during the head movement. So he's fixating on the object and I'm having him move his head. So he had his eyes fixated on the top X. I instructed him to keep his eyes on his head up at X, but took his eyes to the lower X. And then I told him to follow with his head, tilting it down. And then we had the same thing going to the right. I had him move his eyes to the right while keeping his head down. And we start off very slow. It's very monotonous in the beginning, but then as he improves, we can increase the speed, increase the difficulty. We can even add compliant services like a foam pad to stand on or a towel, something that will challenge his balance, which that moves me on to the next part of the concussion, which is balance training. And balance training is just what you think it is. It is simply starting off very basic, standing on one leg. That's very simple. You see he does it quite well. Then I tell him close his eyes. And when he closes his eyes, you can see how he becomes a lot more unstable. The vestibular system is a key component in our balance. So if somebody is off balance, they can easily fall and hurt themselves, either just by reaching or something or from walking. So we do, in essence, do a lot of gait training and balance training so that when these patients go back into the real world, their real jobs, they can basically be in essence full function and be safe. So that is all I have for the concussion. I could go way more, but like I said, I'll keep it short.
That was very good, Doc. Thank you so much. It gives everyone an opportunity to see what your client or your patient may go through. I do want to make one point about concussion and TBI. Most of the mild to moderate TBI patients will get better in a period of time, assuming early active care and appropriate care is rendered. It can be very conservative. Sometimes it's medicine involved on the allopathic side, and these vestibular and cognitive exercises can help bring a patient around relatively quickly, along with the use of aquatic therapy. But one of the things, or two of the factors that really create a complexity is they're not taken care of quickly enough, that these injuries aren't recognized and appropriately treated. And two, the patient's own fear. In other words, your client's fear, they think, I have a brain injury. What's going to happen? Am I going to be able to work? How am I going to care for my family? Will I know my family? Because they'll go online and read about, major concussive types. So it's important that the patient understand they can get better. Now, when there's ongoing headaches, as a lot of your clients probably have reported to you, they have unremitting headaches. A lot of times we have to look back to the neck, the cervicogenic headache, and as Dr. Beecham showed you, the nerves that come from the back of the neck and run up over the head. So many times the concussion symptoms will go away with appropriate care, but the ongoing unremitting head complaint comes into play, and we have to look at many times to the neck for those types of problems. So educating, again, our patients, your clients, to the fact that they can get better will help them become more integrally related in their own wellness. And with that, I'll go to Larry. Thank you.
Well, you guys don't have any questions yet, but if you do have any questions, if you want to type them out, we have a few more minutes. We could certainly bring any of our doctors back on to answer your questions. If you don't have any now, I'm going to put in the chat my email address here at Multi-Specialty, and if you send me an email, I'd be happy to pass it along to the doctor in question, or do my best to answer your question myself, or pass it along to the doctor and have them answer your question. Don't be afraid to use the things that we've shown you. I've thought a lot. I think I sent the email to the wrong place here, so let me send it out to the entire group, not just the Trial Lawyers Association. We've had lawyers come to us and say, it really didn't have the effect of an injection until I asked your doctor to show me what the needle looks like that they do pain management and take a picture of it. So don't be afraid to use pictures of these hot pack stim machines in your presentation to show them to your client. Is this the machine that you used that was hooked up? to the wall or anything like that. I hope everybody's had an idea or got a better idea today as to these physical therapy modalities. I think as a trial lawyer, the better we understand these things, the better we can explain them to the triers of fact. The question just came in, the protocol for referring a TBI to a neurologist once the TBI is suspected. I could certainly tell you from our perspective as a company, once the patient is evaluated either by one of our chiropractors or one of our medical doctors, whoever their first point of contact is within our company, if they need to see our neurologist that we have now, we make the referral. Dr. Taylor, one of the questions, the sample questions I shot to you this morning was, can a chiropractor diagnose a concussion? So I'm glad that you popped back on. Maybe you can help answer that question.
Yes, a chiropractor can diagnose a concussion. There's no x-ray you can take like you would to diagnose a broken bone. Concussions are diagnosed through a thorough medical history, and that's looking at the mechanism of injury. So did they take a hit to the head? But now we're finding that even a simple whiplash, the brain is just floating inside the skull. And as it bounces back and forth in the skull, it's actually getting bruised. A concussion is a bruise of the brain. So once a concussion is suspected, every doctor is different, but in my expertise, if I suspect the patient has a concussion, and I've had several concussions myself as an athlete, I will, as soon as possible, get that patient in to see the neurologist. Just because I'm a chiropractor and I believe in treating the body naturally doesn't mean that these patients don't need some kind of medication to help decrease the inflammation of the brain and get them some relief as well. We have another piece of software I didn't get to demonstrate today. It's called impact testing. And this is another thing, just like the RehabCom, that is used where they've done studies and they've come up like what a baseline measure should be. And then I can have the patient go through this software. It's about a 45-minute computer-based test, and it'll tell me if they're having some deficits. The only caveat to that is if they have a previous history of, stroke, where they already have some cognitive dysfunction, you're fairly limited, but chiropractors are 100% able to diagnose a concussion because the brain is a part of the central nervous system, and chiropractors are experts on the nervous system itself, not just the spine.
Dr. Taylor, you're a certified athletic trainer. In sports games like the NFL, do athletic trainers actually diagnose that as well? Or is there really a doctor on the field when they say that somebody's going to concussion protocol?
Nope. If they're so the NFL, obviously the NFL has medical doctors right there. But in college settings, not all colleges have medical doctors. There's an athletic trainer. And in high school, there's not a medical doctor on the sideline. There's an athletic trainer on the sideline. That athletic trainer is taking the patient through any kind of neurological tests, cranial nerve testing, balance tests. You're doing eye movements to see, is that patient getting eye twitching, nystagmus? And that the athletic trainer puts that patient into concussion protocol.
I just thought that was sort of a relevant follow-up because of how concussions are viewed in society and sports these days. Well, don't be shy. If anybody else has a question, please. I think we got another one. Look at that. The question is, when would DTI imaging or VNG testing come into play in reference to a traumatic brain injury? Dr. Taylor, is that similar to the impact test that we do, or?
Yeah, so you can't really do, you can do a brain CT or MRI that would show if they had a bleed of the brain. But that takes you down a different road and not so much what we see in the office. Our neurologist does like to order brain MRIs because he does want to see if the patient had any prior injuries to the brain. You can see I'm sure everyone's heard of the CTE and everything going on with the NFL players. So that's why he likes to order MRIs. The testing, I want that done ASAP. As soon as the patient comes in the office, if I suspect that they have a concussion, well, the next thing I'm doing is we're doing those testing because I want to see where they are. The sooner you get into it, the sooner the patient can start to improve, and then the sooner they get back to work and their normal daily lives.
Okay, and another question was the name of the software that Dr. Beecham used. It's called Anatomy 5.0. It's certainly available on the market, you know, for lawyers or for anybody. We purchased the licenses for it for our doctors. I think, as he told you, it takes a little while to get used to, and it's a great presentation tool in front of a judge or jury, whether multi-specialty is the treating doctor or not. But obviously, our doctors are getting very versed at it to use it as trial exhibits. And Dr. Beecham was probably a little trying to be a little not show off, but he's actually, when he said he's got some verdicts, he's gotten some he's helped our colleagues get some six-figure verdicts in some of the tougher jurisdictions in the state of Maryland, such as St. Mary's County. And I know from what I always hear, DC Superior Court's a tough place to have a jury as well. I do not see any other questions, but I do, like I said, did put my email address in the chat for everybody. Dr. Thorne, you want to kind of give us a little overview of multi-specialty and any other information you wanted to provide?
Well, you know, I think we've already done that. And we do have a multidisciplinary approach, and I think Jessica said that best. We stay in our lanes and we utilize a team approach to give your clients, our patients, the best possible outcome, not only with regard to their health, which is our primary concern, but also to appropriately document and create the value you all need and the tools you need to maximize your representation. I want to thank you all. It's been a long program and there's been a lot of information. I learn something new every time these folks step in front of the camera. Question for Mary, will this video be available to your members?
Absolutely. I have it recorded, and I will make it available to everybody who wants to see it. I'm going to send it out to all the members and anybody else who's on the registration list.
I'd love to have a copy if you wouldn't mind. And I thank you very much and your members for your time and all you do for the community. Thanks for allowing us to get together and show you a little bit of what we do and what's being done in the field for the most common types of injuries that you all run into in a personal injury and workers' compensation practice. Have a great holiday weekend, and thank you all very much.
Thank you, everybody. It was an excellent program. Stay safe. Bye-bye.